Acute coronary syndrome, which is ACS, is that group of symptoms with cardiac ischemia. And so this is temporary, or more serious, becomes an AMI, right? So if we have that ischemia that comes with exertion, that's that angina pectoris, right, which is Latin for chest pain, or the AMI, which is persistent, and that actually means that the ischemia is not being fixed and we're having cellular death as a result. The symptoms are very similar, and they are treated under the same way in the acute coronary syndrome complex, right? And so we'll get into that algorithm of how we treat chest pain, regardless of whether or not you think that's an AMI or not. And now we're talking about angina pectoris again. That's pain caused when the heart tissues are not getting enough oxygen, ischemia for a brief period, right? It is what we would call stable if the pain goes away with rest, and it's unstable if at rest the pain does not go away. It can be relieved promptly and there's no change in the cardiac rhythm pattern. All right, again, so that can also be a result of a spasm of an artery, but it's usually a symptom of that narrowing of the coronary arteries from coronary artery disease. And again, as that narrows, the absolute amount of flow that can pass through it is completely regulated. It's very hard to override with pressure. And so any of the tissue that's below that narrowing or blockage is going to end up being ischemic, because it requires a very definitive amount of blood flow to cause perfusion. And that's being said when it says that it occurs when the heart's need for oxygen exceeds the available supply. And so this could be physical or emotional stress, right? Just like I was saying before, that autonomic nervous system, right? So if you're physically active and you're asking the heart to increase its ability to contract to supply oxygen and nutrients to the body, we can actually cause that cardiac ischemia, right? Because when you ask it to work harder, it needs its own oxygen and nutrition supply first. And then the same can be had from emotional stress, right? So we get that kind of hormone dump from emotional stressors, and the resulting increase in cardiac output happens from the epidumps or the norepidumps and things of that nature. So when we're talking about that chest pain or angina pectoris, right, or quite simply what we call angina, the pain is usually described as a crushing or a squeezing. Pretty often people may actually describe that as like an elephant is sitting on their chest or something along those lines. That tends to kind of be passed down from person to person to person when they're discussing that, and it seems to be a very similar complaint. The are again generally classified as stable or unstable. Stable being when that patient or the person that you're interviewing, if they are at rest, the pain goes away, we would consider that stable. If the pain does not go away at rest, and we're looking at as more unstable. It's really hard for any of us in the field to distinguish the chest pain from a true myocardial infarction. And without diving too far into it, for every time we see a patient who has an obvious AMI, we are thought to have missed up to 2 people with a non-obvious AMI. So you really want to treat these patients all the same, regardless of what it is that you feel like it might be. If they say they have chest pain, you should treat them for chest pain. AMIs are the leading cause of death in the United States. 90% of these deaths are caused by an arrhythmia, and these begin in the early hours after that initial insult or the infarct, right? And so as that tissue becomes hypoxic and it starts to die, the arrhythmia can start. If we treat this really, really early in the stages of the ischemia, and we get them to the appropriate facility where they can have a stent placed or have the angioplasty, we can prevent those arrhythmias from happening, which is then going to prevent the cardiac arrest, right? The hurdle that we're up against as EMTs in the field is that quite often people kind of go into this denial phase where they won't call for hours and hours and hours when their chest pain starts. I mean, it's often estimated that most people will wait 2 to 6, sometimes 8 or 12 hours before the pain is unbearable and they finally accepted that they're having some kind of event that is not going to go away, or they're not confused by other symptoms. And then when they call us, a lot of that damage is already done. So early recognition on our end can be quite possibly the lifesaver for that patient. So again, when you're dealing with anybody that has a complaint of chest pain that's not trauma related, right, like broken ribs or something like that, we always want to make sure that we're trying to treat them for the chest pain immediately and getting them transported to the appropriate facility. So I've said this before in previous lectures, cardiac cells are unable to regenerate, right? It's not like skin, it's not like your liver, it's not even like lung tissue where there's a regenerative process. The brain and the heart are unable to actually regenerate anything that dies. So once you lose that section of heart from the AMI, it's always gone, and that's going to reduce, again, that ejection fraction. So they can be treated with fibrinolytics, which is that kind of clot buster, angioplasty, which is where they're placing a balloon in to kind of like open that artery back up, or they place what we call a stent, right? So they remove the clot and then they put in a metal kind of structure inside that actual artery to hold it open to increase the blood flow distal of the occlusion. So what are the actual symptoms of an AMI? Well, we all kind of know, like they're going to have that, I feel like I'm being crushed or squeezed, or I have some kind of pain in the chest, right? And so there's often accompanied onset of weakness, nausea, and sweating. And then they can have that chest pain, pain in the lower jaw, the arms, the back, the abdomen, or the neck. And generally, we like to say anything from the navel to the nose in a patient of appropriate age should be considered a possible AMI event. So make sure that you're doing a pretty good history and try to figure out and decipher what the patient is telling you to try to get on the correct pathway. If they have an irregular heartbeat, that's usually a red flag for you. If they have syncope, that's really abnormal, right? People don't just walk around and faint. So if somebody says that they had a syncopal episode or they fainted, right, we should treat that as an abnormal cardiovascular event. And then if they have dyspnea, that's the problem where they feel like they're short of breath. That's telling you that something's not being perfused and they're trying to unload oxygen at a greater amount intrinsically, right? Something is driving their demand to breathe more rapidly or more deeply so that they can try to unload oxygen, because the body is trying to regulate the inadequate perfusion or the shocky kind of sensation from the tissue not being oxygenated and given nutrition. So if you see pink frothy sputum, that's generally the left side of the heart has the inability to pump against the rest of the body. So that blood starts, or the plasma, it really is what's being backed up into the lungs. It's being pushed across that alveolar membrane. And then when somebody's coughing and spitting up this pink frothy sputum, that's the actual red blood tinging of the sputum that's coming out of their mouth. And then obviously sudden death, right? And so most cardiac events are where we have a cardiac arrest is a sudden onset of ventricular fibrillation. A little bit more on the pain of AMI. The most common symptom is that chest pain. They're going to pretty typically tell you that they have a substernal chest pain. It may radiate into the left arm or up into the neck. Sometimes some patients will tell you that it's radiating into the right arm or into the back, right? It's really, really hard to kind of pinpoint and just say, well, this symptom is guaranteed. No two people are going to be the same, so try not to get caught into that trap. They may or may not have this pain caused by exertion, and again, if they have that ischemia when they're exerting themselves and it goes away when they're at rest, that is what we would call a stable angina, right? And so we understand that they're increasing their myocardial demand beyond what the blood flow is willing to do. But they become unstable when they start to have this kind of effect when they're at rest or they're sleeping, right? If it doesn't resolve after a few minutes, and it goes on for 30 minutes to a few hours, this is more of a red flag for us that we really need to have this evaluated right away. Nitroglycerin is kind of not in vogue locally. I think most systems are going away from that because it tends not to have the intended effect. It's given to kind of vasodilate the coronary arteries and increase a little bit of blood flow. So a lot of people who have cardiac disease where they have this ischemia problem will actually be prescribed nitro, and it's in your scope of practice to use that as a treatment for chest pain. Again, this is telling you always consider AMI even if chest pain is not present, which really means if they are having some kind of symptomology that may be related to chest pain, you should consider it. So again, that kind of knees to navel kind of pain complaint that's unexplained by something else should be considered a cardiac event and investigated further. So your physical findings, these patients are going to kind of have that fear or impending doom. They're frightened. They'll look pale or kind of gray, and that's because they're not perfusing, right? They're kind of getting that shocky look. They will have an increased pulse rate because they're actually trying to perfuse tissue even though the heart is in a failing pattern. Blood pressure is going to be elevated initially until it becomes so significant that they're not able to push against the systemic vascular resistance, and then blood pressure will start to drop. They're usually complaining of a difficulty breathing, and then this can all lead to sudden death, right? And so again, cardiogenic shock or things of that nature is nothing more than the heart is unable to actually provide perfusion, right? So they go into a shock-like state or shock state because of the cardiac output. CHF, congestive heart failure, is a long-term kind of process, and we can get into that a little bit deeper in another section. A little deeper into the cardiogenic shock, right? That's the heart lacking the power to pump enough blood through the circulatory system. And again, this is most often caused by a myocardial infarction or an AMI. And that's because we've lost a big chunk of that cardiac tissue, and now that ejection fraction has gone down significantly, and the patient is now going to have that lowered blood pressure, and it puts us into that shock situation, right? Because cardiac output requires X amount of beats with X amount of pressure being delivered so that it's actually perfusing the tissue in the body. And so this can actually immediately onset or come on, as long as 24 hours after the initial cardiac event. You want to make sure that you understand the difference between cardiogenic shock and then hypovolemic shock, right? And this should be fairly obvious unless the bleed creating the hypovolemia is like a GI bleed, which is really hard to detect unless somebody can give you good, accurate history and tell you, kind of the signs and symptoms of a GI bleed, or if the hypovolemia is coming on from, say, something like a sepsis, where the plasma and the interstitial fluid is leaking into the third space, which is around the cells and the rest of the body, because the vasculature has become more permeable as it relaxes. All of your patients that have any kind of chest pain should get the same evaluation and initial treatment. You should pay particular attention to the respiratory effort, the presence of peripheral or pulmonary edema, right? And so that peripheral edema is that pitting edema in the lower legs and the feet, which is the right side of the heart having a hard time keeping up with the incoming flow because it's just not actually working, and so it tends to back up into that interstitial space. And those are the people that if you push into their leg or onto their foot, they'll develop that pit where you pushed your finger into it and it doesn't rebound right away, right? It can take 3, 4, 5, 7, 8 seconds for it to kind of flatten back out, right? And we call that pitting edema. The pulmonary edema is that person that's coughing up and spitting up that pink frothy sputum, and that's the left side of the heart again that's actually unable to keep up with the fluid coming into it, and so it starts to back up into the lungs. These people all need to be transported, right? There's no time to play with them. We're always going to look at that person and we're looking to do the right thing, which is get them to the appropriate facility as quickly as possible. They're going to be generally full of anxiety and restless. You're going to see them. They're really kind of just working to breathe. They're pale and they're clammy, right? And that's because the body now is in cardiogenic shock. And so if it's in shock, it's going to start shunting, and then the skin and the peripheral kind of tissue is now in a state of hypoperfusion. And so those are the symptoms of that. As the shock gets worse, the pulse rate's going to get higher until the body is unable to compensate, right? Remember that compensated shock where heart rate increases, blood pressure increases to try to compensate for the lack of perfusion. And then as the body systems wear out, heart rate will continue to increase, blood pressure will start to drop, and then ultimately the heart rate will start to lower until they go into a rest. So when we're talking about treatment for that cardiogenic shock, you want to position your patient comfortably. If they are in some kind of left-sided heart failure and you lay them flat on their back, they will literally feel like they're kind of drowning. So we want to put them into a good position. We want to give them plenty of oxygen, right? So we're not looking for an oxygen level of 100, right? We want between 90 and 94. And then if we have to assist their ventilations, we will. CPAP is a great treatment for people who have a good blood pressure, right? And so you would be outside of the cardiogenic shock kind of algorithm at that point, because shock means that they're not perfusing. But if they have a good blood pressure, giving them something like in somebody who's in CHF, it may actually be the appropriate treatment. So remember, you have to have a minimum systolic pressure of 90 to give somebody CPAP, but that is a great tool for left-sided heart failure. Make sure that you cover this patient, and you want to make sure that they're conserving their body heat. We don't want them to feel cold and to start shivering, which is going to increase myocardial demand, because now the body is actually trying to create heat by making multiple contractions, and then we're just going to kind of create a cascading event where it just gets worse, right? Give this person some IV access. You want to give them their fluid bolus of 20 mLs per kilogram, and that's for hypotension, right? But make sure, I need you guys to remember this, that you're listening to lung sounds. If they're already very wet with that rhonchi, or what we call crackles, you can actually exacerbate the problem, right? This person could just ultimately end up drowning in more fluid if you're giving them that large fluid bolus. So anytime you have somebody that's in some kind of cardiogenic shock, or shock-like symptoms that you suspect have cardiovascular origins in nature, you want to make sure that you get lung sounds before you give them that fluid challenge to try to assist the blood pressure. And again, there's no time for stay and play, right? I don't like that term, period. But we want to get these people to the appropriate facility as quickly as possible. CHF, congestive heart failure. This is where the ventricular heart tissue is damaged, and that could be because of the AMI that was previously or is currently being experienced, right? Or it could be thickening of the tissue where it's unable to actually create enough ejection fraction, right? So if we keep building up thicker and thicker heart tissue, the chamber gets smaller as a result, and it's unable to actually keep up with the cardiac, or I should say the body's demands for the oxygenated blood flow that's carrying nutrition and oxygen out to the rest of the body. So this is just talking more about that left or right-sided congestive heart failure, and we've already kind of talked about this, about where things are happening. So if it's distal in the legs, that's generally a right-sided heart failure. And if it's backing up into the lungs, that's left-sided. Most right-sided heart failure is a result of left-sided heart failure. If you have a patient who has congestive heart failure, again, in this particular slide it says CPAP may not be beneficial. If that patient has a blood pressure of over 90, CPAP is very much indicated in anybody with wet lung sounds. We want to make sure that we're actually very aggressive with CPAP in the right cases. If they have a decreased blood pressure, right, if they're I should say hypotensive, right, you don't want to actually exacerbate that, because when we hyperinflate or create the lungs to have a extended expansion, we can actually push the heart against the vena cava, which is going to slow blood flow into the right side of the heart and actually even increase that hypotension. So you want to make sure that they're sitting upright and use the appropriate device if they need oxygen, right? And so again, what I don't want anybody to think of is that CPAP is automatically excluded from this. It's very patient dependent, and one of the biggest indicators is what is their systolic blood pressure, and if it's over 90 and you think it's going to help them evacuate that fluid from the lungs, please do give it to them. Again, you want to start that IV, reassure your patient you're trying to coach them, you want to make sure that you get them to the hospital, transport.